Okay, great. And hopefully you all can hear me okay. So hi again, everybody. This is Jennifer Gross at Point Right. It's been a while since we've done one of these breakouts and even longer since we've done one in person. But I'm glad to be able to have a session just for us MDS coordinators, or you MDS coordinators, but I still consider myself one of you after all these years. Today, of course, we're talking about PDPM. With some of the impacts of COVID-19 and some of the things we're seeing in your data, but also just from a general sense to discuss any questions or concerns or difficulties that you might have from a compliance standpoint with just getting all of the million MDS pieces in the right place in order to support your PDPM case mix and your billing. So please feel free during the presentation, if you have any questions, just chat them over to me. Temi just put a message in the chat saying just that. So just send me over a chat message if you have any questions, and also we'll have some time at the end. Okay, so just a quick disclaimer, this presentation is informational and educational only. So I'm going to talk about regulations. I'm going to be talking about guidance from the REI manual and from other CMS and CDC guidelines. But that's what the regulations say. Your interpretation, of course, will be up to you and your organizational legal and compliance teams and your corporate policies. Okay, so first of all, we're going to kick this off with an overview of some of the main PDPM case mix drivers that we have found in the data from Nexus participating SNFs and how they've changed quarter over quarter. I pulled data from April 2020 through March 2021, so just about the 4 quarters from the most recently completed calendar quarter. And it's interesting to see kind of the impact of pre-COVID and, well, April 2020 was during COVID, but you can see some visible changes in the case mix drivers that are directly or indirectly related to the pandemic. And then we'll talk about some potential compliance areas or area nuances in MDS coding, both related directly to COVID-19, as well as other general PDPM drivers and the types of interdisciplinary communication and documentation that are needed to just make sure, again, that all of the pieces are in place since PDPM has so many moving parts. Okay, so first of all, let's talk about the data. So the overall PDPM drivers that we have been seeing in Nexus facilities. Oh, yes, I'm sorry. Thanks for that message. Yes, there are handouts. I don't believe I can attach them to a Zoom meeting, but I will send them out after the presentation. I just created the handouts this morning. Thank you for that. So first of all, let's talk about the specific PDPM drivers. Now, I'm not going through every single component of PDPM because that would take an entire hour just by itself, but some main drivers that we have seen that are impacting PDPM rates from the MDS data. So what we did to pull this information is, of course, we have your center's MDSs. So we ran some of the PDPM grouper, ran the data through the PDPM grouper and calculated the case mix components and the average per diem rates from your assessments from Q2 of calendar year 2020. So from April 1st, 2020 through calendar year 1 of 2021. So through March 31st of this year. Now, when I talk about the average per diem rates in my first graph, these are the per diems that are from day 4 through day 20, so not factoring in the variable per diem adjustment. In particular, I was looking at PDPM payment drivers that are either directly or indirectly impacted by the pandemic, but also just give a broader look at some general interdisciplinary documentation and assessment processes. So, First of all, let's look at the trend over time. So again, these dollar figures are average per diems. This is for all of the Nexus participating SNFs that we have in our system. And you can see the trend over time beginning actually a little bit earlier, March 2020. This may be incomplete data, but right before or just as the pandemic was beginning. And then you can see the huge spike here with the initial surge of infections on the East Coast jumped up over almost $40 on average per diem from between March and April. Of course, not surprising considering some of the drivers involve things like isolation. And this was right when the COVID-19 ICD-10 code became active on April 1st as well. Then there was a tapering off in the per diems. And then from July through, what do I have, through September of 2020, you see kind of a lull here. And as we know, there was a kind of a midsummer lull. It was COVID, of course, did not anywhere close to completely go away, but after the initial surge, you made it through. There was a little bit of a lull in the middle, and as you can see, that this is actually kind of reflected in the average per diem rates because really ill patients were fewer, but getting back to quote normal with things like therapy and elective orthopedic surgeries and the things that you were used to dealing with hadn't really gotten back on track yet. So you have that kind of lull in the drop in the per diem on average. But then there was a ramping up both from some pickup in therapy, rehabilitation, surgeries and such like, but also in the unfortunate post-holiday surges in COVID-19 that we found in the data for the Maryland area and in your counties in particular. So there was a peak around December back up to $600 on average per diem, and then a ramping off. So you can see that the pandemic, even though the COVID-19 itself only impacts directly a couple of the components of PDPM, it can have a really appreciable overall impact on the per diem as a whole, just because of the indirect effects of the pandemic on the facility as a whole. There's my there's my lull. I forgot about my animation. So first of all, let's look at the main payment drivers, of course, that are most obvious. So for the isolation precautions, which put the resident or patient in the extensive services nursing component category, as well as give a non-therapy ancillary point in the NTA component. So for isolation, what we are looking at here is for Nexus SNFs compared to the Point Right national average, which is approximately 2,400 facilities nationwide who submit MDSs to Point Right. So a pretty broad sample cross-section of facilities throughout the country. So you can see that right at the beginning of the pandemic, isolation and the associated extensive services were way higher for Nexus facilities compared to the overall Point Right national average, which when you think about it is not terribly surprising considering how geographically not isolated, but the pandemic hit the East Coast and the Pacific Northwest first and the hardest compared to the rest of the nation when it eventually spread due to other events. But at the very beginning, down in Maryland, you folks were hit very hard. So you can tell that just simply from looking at the isolation, which is not a normal occurrence. Then you can see that there was a quarter of a lull in the pandemic and in the rate of isolation, where you were actually below the national average. The national average continued to climb through October through December, but also picked back up in Nexus. And now you are back, or for the Q1 of 2021, rather, your centers are back below the point right national average, which is kind of stabilized around the 11% point. So again, COVID has by no means gone away, but isolation is a pretty quick way to identify where it is happening because it's not a normal occurrence in the SNF. Now, of course, we have the COVID-19 primary diagnosis as well. Now, the assumption is that if you are treating a resident for COVID-19, and this is not always a blanket assumption, but that is most likely the primary diagnosis and the primary reason for the SNF stay. It's usually not something else that is primarily driving the SNF stay during these specific times. But that doesn't necessarily mean that that person will be on isolation. So don't automatically think when you look at the data that the percentages of COVID-19 primary and isolation should be exactly the same, but because remember the criteria for isolation, which we'll be talking about a little bit later in the presentation. So if you have somebody on isolation, most likely you're going to find that diagnosis in their diagnoses, whether it's the primary or one of the secondary diagnoses, but just don't anticipate that they will be exactly the same. However, these rates tracked very closely, slightly more COVID-19 primary diagnoses compared to isolation, April through June, drop off July through September, back up again October through December, and then around 10% January through March, but higher than the percentage of isolation. So remember that around this time, at the beginning of this quarter was when vaccinations really started to ramp up. There was a monoclonal antibody treatments, which we'll also be talking about a little bit later, that started ramping up. So other treatment options and preventive options have started to become available, so that strict isolation may not strictly be necessary for some COVID patients, and cohorting might be a more appropriate way to approach it, in which case you want to make sure that when you're capturing isolation on the MDS that it truly is strict isolation. So next up are areas that are not directly impacted by COVID, but may be indirectly impacted by COVID. For example, swallowing disorders and mechanically altered diets because of the massive disruption in the life of the facility, including dining. What we were used to of having a nice big dining room full of people with lots of staff there and people to watch the residents as they're having their meals and help them with their eating, to identify when they might be having a problem swallowing or complaining of pain or anything like that, as well as ensuring documentation of the basic things like an altered consistency diet. Now, not a huge impact during these time periods, but however, you notice April through June of 2020, the rate and nexus of identifying swallowing disorders in section KO100 was down to 13%, which is over 4% below the point right national average. And this is kind of an anomaly because normally your centers, what I'm seeing in your data is you're running right alongside the point right national average as far as these payment drivers are concerned. So you're very consistent with your peers across the country in capturing these areas of the MDS. So I can attribute this most likely to the fact that there were restrictions on congregate dining put into place around this time, just simply made it more difficult, unfortunately, to identify problems swallowing during meals or just simply have the time to document or communicate these swallowing issues. But that translates into fewer identified swallowing disorders, most likely, and it impacts your SLP case mix groups. but that has kind of bounced back to around the baseline. And actually your centers are running 1 or 2% above the point right national average in identifying swallowing disorders. So you're watching your folks again. So that is great. That seems like signs of normalcy, but that's a little strange to say. For the mechanically altered diets is a little bit more straightforward, because if the dietary orders are in the record, they're in the record. And hopefully this means that those appropriate consistencies of food are being provided. But your centers have run pretty much even with or ahead of the point right national average slightly throughout this time period, varying between up and down about 1 or 2%. Quarter to quarter. So not a lot of change here, but it was striking the decrease in identifying swallowing problems that first quarter of the pandemic. And then the other areas that are potentially indirectly impacted by COVID for different reasons are the depression qualifiers and the cognitive impairment qualifiers, which impact both nursing, and the cognition impacts SLP, of course, as a comorbidity. Now, straight up depression rates have gone up, even though it became a lot more difficult to conduct these resident interviews. So while the rates of depression for the Nexus facilities, and this is not diagnosed depression, of course, as you know, as MDS coordinators, this is from the PHQ-9 interview. From the Nexus facilities, you were running a little over 2% below the point right national average as far as rates of depression. But the next quarter, you were up 4% over that previous. So it was a very stark change, and then up another 4% October through December, and then up another almost 3% January through March. So it's very unfortunate. It's good that assessment is being done and identifying these signs of depression, but and we're seeing this nationwide, that rates of depression have also gone up since prior to the pandemic for very obvious reasons. But the key takeaway here is that the Nexus centers as a whole, of course, there are variability between your individual centers, but you have been doing a really good job at capturing that PHQ-9 score and making sure that that is documented and presumably care planned for. Cognitive impairment, actually, there was some change quarter to quarter here. We are talking about identifying cognitive impairment either through the BIMS interview or from the staff assessment. Either or requires a staff member either administering that interview or doing the staff assessment, which requires one-on-one contact with the resident. So it becomes a lot more tricky when you have these precautions in place. But the rates of depression cognitive impairment identified in the Nexus centers was pretty much slightly above, but pretty much neck and neck with the point right national average at the beginning of the pandemic, but then actually had increased had decreased the next quarter, but was 2% above the point right national average. So everybody's rates of identifying cognitive impairment dropped significantly, really, from one quarter to the next quarter. And that simply could be a factor of difficulty in administering those assessments. But the rates of cognitive impairment spiked up again another couple of percent October through December, and then kind of stabilized around 50% January through March of this year, a little bit below the point right national average. So the important point is that being able to administer these assessments, whether it's a resident interview or doing a staff assessment, is really important, both for care planning, of course, particularly with the cognition and the depression, but ensuring that that these smaller pieces in the PDPM puzzle are being put into place. So just looking at the chat, there are not any questions so far. Feel free to shoot them at me as we go through the next section. So let's talk about a few areas that have an impact on PDPM that either you as MDS coordinators or your interdisciplinary team as a whole play a role in, and your documentation. And of course, the first key point here, the kind of thing that holds everything together is the primary diagnosis, which is intended to be an interdisciplinary process. Ideally, there's not one department or discipline that is running the show here, because everyone on the interdisciplinary team has input in caring for this resident or patient in your facility. Now, you do have to have that documentation in place, of course, from the physician or nurse practitioner or PA as a driver behind what that person is doing, receiving skilled services in a SNF in the first place. But it is up to your interdisciplinary team to determine what specifically is that primary driver of the diagnosis, because you're planning the care around this particular resident, and just answering the question, what's the main reason for admission to the SNF and for requiring SNF treatment, is really important, because the typical skilled nursing facility or nursing home resident has multiple conditions that in and of themselves would benefit from treatment in a skilled nursing facility, right? You have somebody with a history of multiple falls who needs physical therapy, who has COPD with a recent exacerbation, who has uncontrolled diabetes, who has difficulty swallowing. You know, there are all kinds of various reasons for why a person is unable to live outside of a SNF setting and receive the care that they need. But what is the main reason? Because you can only pick one primary diagnosis. Of course, COVID tended to be the number one throughout 2020 or from April 1st going forward. But just as a general rule, coming to consensus on that primary diagnosis and then making sure that the documentation and the care plan is centered on that diagnosis and things that are related to it is really important to tying together the justification for that SNF stay. Now, of course, you as MDS coordinators know the requirements from the RAI manual for every diagnosis on the MDS. You have to have that physician or physician extender diagnosis in the documentation within the last 60 days. For the primary, it has to be related to the reason for accessing the Part A benefit. And then that diagnosis has to be within an active status within the last 7 days, affecting the resident's current function and their care plan. Now, talking specifically about the COVID-19 diagnosis, the ICD-10 code U07.1. This was a new diagnosis that was implemented April 1st of last year, and this is specific. The ICD-10 guidance from the CMS website. This is actually the fiscal year 2021 guidance, but that's currently in effect through September 30th of this year. So I put up that link there. But this full guidance is in general about ICD-10 coding, but there is a section on coding PDPM for skilled nursing facility care. So you can download that from the link there. But basically what we are looking for here is this ICD-10 code is assigned only for a confirmed case that has been documented by the provider. It could be including a positive COVID test result, or physician's documentation that this patient has COVID-19 right now. This is an active case. I double checked this in the CDC guidance because we want to make sure that that I'm giving you the right information. And these guidelines do say that there doesn't necessarily have to be a positive test result as long as the physician in their clinical judgment document that this person does have COVID. There simply may not have been testing available at that time, although that's obviously less of a problem than it was back in last spring. So that U07.1 diagnosis is reserved only for confirmed cases of COVID-19, but there are other specific other diagnoses that could be related, such as a pneumonia or an acute respiratory distress syndrome or something related to COVID-19. You would code based on the causative organism. So pneumonia due to coronavirus disease 2019 is J12.82, for example. So you could code that in I-8000 with COVID-19 being the primary diagnosis in I-20B. Now, if there is a diagnosis that you need to put into place for somebody who doesn't have COVID or it hasn't been confirmed yet, but who has documented contact or suspected exposure, I'm missing an E there, to COVID-19, there's a Z code for that, Z20.822. So you can do that as well if there is documentation. Just know that you can have multiple diagnoses that are related to the COVID-19 infection, with COVID being the primary medical reason for the SNF care. But you need it in the documentation. Now, just as an FYI, the fiscal year 2022 proposed rule was released as usual in the spring. And one of the things that CMS mentioned in the proposed rule, there's not huge changes proposed to PDPM, although they are saying that they're probably going to be tinkering around with the rates to make it more budget neutral, like it hasn't been. But the ICD-10 mapping is going to change to incorporate several codes that right now are return to provider, and they're still return to provider right now, but will map to a clinical category going forward. So that includes, I don't have all of these codes memorized, so bear with me here, I apologize, but things like anoxic brain injury, vaping disorder or vaping related disorder, which is a pulmonary diagnosis. So, you know, the ICD-10 codes are continuously evolving as new diagnoses are being recognized, and some of them are being identified from provider feedback as being relevant to a SNF stay. And so CMS takes this information in and makes a determination, are they going to add this to map to a clinical category? If a resident is admitted to a skilled nursing facility and their primary diagnosis is anoxic brain injury, then that code shouldn't be returned to provider. It could very well be the primary diagnosis and should go into the acute neuro clinical category. So none of this is final yet. And the ICD-10 codes update every October 1st, the same as the fiscal year. So that is to come. Expect to hear more from CMS about that. All right, so in addition to diagnoses, often related to that diagnosis is the need for isolation. So just as a reminder, because there was quite a bit of pushback in the provider community, and I understand their reasons for this, asking if CMS could please loosen up the requirements for isolation, because you can only isolate so many people in one building in a single room. And some centers that were especially hard hit, who didn't have a lot of extra space for single room isolation, were cohorting patients who were COVID positive together. That's just the way it was in this emergency situation. But CMS didn't budge on the requirements for coding isolation. So just remember that the resident has to meet all 4 criteria in the manual on page 05, single room isolation, epidemiologically significant, highly transmissible contact or airborne or droplet transmission. The resident cannot leave the room except under certain controlled circumstances recommended by the CDC. And all services have to be brought in to the resident's room during this time period. Now, even though all these criteria have to be met, including the actual organism has to be in place to be causing this isolation. That's the first criterion, that the resident has to be on isolation for that infection that is easily spread. But remember, Section O has a 14-day look-back period since admission to the SNF, not prior to admission, but it doesn't have to be for the entire 14 days. So there might be a time period where a resident has to complete an isolation period for 5 days or something like that. Usually the PUI cohorting or isolation would, at the very beginning of the pandemic, last up to 14 days in some facilities. But if there wasn't a confirmed COVID diagnosis, then you're missing one of the 4 criteria. So you just want to make sure you have everything in the documentation. So make sure, if the resident is meeting all of these criteria, that you have documentations in place of that active diagnosis, presumably COVID, but it could be another equivalent organism, that the resident is alone in their room. All treatments and all therapy are being brought in. They don't have a roommate, and that you're maintaining transmission-based precautions. Now, if a person has to go out, for example, to dialysis, then if it's medically necessary, that person you can still maintain isolation during the transport, but CDC has specific guidelines for how to handle the precautions during that transport period, which, you know, a lot of that is being done now anyway as a standard of practice of infection control during the pandemic. Okay. And again, just as a reminder, I kind of talked about this on the previous slide, the distinction between cohorting and isolation is really important because isolation, again, those guidelines, those requirements, really, they're hard and fast. They have not changed. So even cohorting residents together who had the same infection, transmitted the same way, they might have even gotten infected at exactly the same time. But if they're in a room or in an area together, they're cohorted, they're not isolated. Even if you have transmission-based precautions in, and you might have some caregivers that are assigned specifically to that wing with their own entrance and exit, and no contact with the other facility, that's cohorting, that's not isolation. So you want to make sure that you are not trying to capture that isolation qualifier and extensive services qualifier when in fact what is actually happening is cohorting. That's a big compliance risk. And you know that this is easy picking for CMS and to send in the max and take that right back. Okay, now this, I wish I could give you a specific answer about the monoclonal antibody therapy, because now that this is available and there are some SNFs who have been piloting antibody therapy programs and have pretty mature programs. I did some searching. I suppose if I searched longer, I might have found a specific answer, but I haven't found anything from CMS that has specified if you provide monoclonal antibody therapy to a resident, how you code it on the MDS. Kind of important because it could be either an IV medication or a transfusion, because the antibody technically is a blood product. It's derived from blood, but you know, you don't think of it the same as plasma or platelets or whole blood or anything like that, but it is derived from blood. So there's been a lot of debate about this, but CMS hasn't specified exactly how this is supposed to work on the MDS. Now, either one of those two, IV meds or transfusions, as far as nursing is concerned, that puts you in clinically complex. So that doesn't make a difference there. But for NTAs, IV medication gets you 5 points and transfusion only gets you 2. So chances are your corporate policy is going to be erring towards coding IV meds rather than transfusions. But again, when I'm doing some research on this, I see that MDS coordinators have done what they should do. If you have any questions you can't get answered elsewhere, is to contact your state RAI coordinator and follow their guidance. But I'm hearing that different states are telling people different things. So I really wish CMS would come up with some guidance about this. Maybe when they release the updates to the REI manual, there might be something about this, or at least an example in the manual, I can hope. But for right now, what I recommend you do is contact the Maryland State REI coordinator if you have not already, document their guidance, get in an email if possible, and follow that guidance consistently. Do not try to double dip. It's just like dialysis. You know, you can't code IV medications and dialysis separately if they went together. So don't try to double dip. That's just kind of a standard in MDS coding. Pick one or the other, but also keep a list. You know, those folks that received this therapy, keep a list of those ARDs that you might have to modify just in case, because you certainly want to make sure that you are prepared if those records come under auditing. It's amazing how nitpicky this can get, but this is a pretty big question and there hasn't been any clarification from CMS. I'm just going to pause for a second, get a sip of water. So far, there haven't been any questions, but just as a reminder, you can use the chat box to send any questions to me. And I'd love to hear your input as well. Do you have policies if your centers are giving antibody therapy? Is there a corporate policy about this, or about anything else that I've been talking about so far? I'd love to hear your input on this. Okay. So let's talk about some other PDPM considerations that are not strictly COVID related. But of course, remember that all diagnoses are important, not just clinically, because if it's not an active diagnosis, it's not going to be coded on the MDS in the first place. So any diagnosis that meets the criteria for active in the REI manual is going to be impacting the resident's plan of care in one way or another. So it just makes sense to make sure that's captured. Oh, good question, Tiara. I'll get to that. So just make sure that you're capturing those as if you absolutely can. So in I-8000, making sure that you get the diagnosis and the right diagnosis code, like particularly diabetes, because there are combo codes that you could get, that you could code on the MDS instead of just a straight code for diabetes. If you have an insulin-dependent diabetes with peripheral neuropathy or something like that, getting the right code makes it much more specific on the MDS. But the diagnosis checklist is still there. It's still important. I didn't include my last word there. And it's important just as a blanket policy. You know, the general rule of thumb, which used to be specified right on the MDS form, but it's not specified anymore, is check all that apply. So somebody who has that diabetes with peripheral neuropathy, first of all, you're going to check off the box for diabetes. And then you can add the specific code in section I-8000. You don't want to neglect both of those sections because they both count in the SLP comorbidities, in the NTAs particularly, and in the nursing component. For example, COPD, you have to check the box. Just coding the diagnosis in ICD-10 and not checking the box, you're missing a lot of information that goes into the case mix groups classifications, as well as things like quality measures. The QMs focus very heavily on that checklist, and almost none of the QMs, possibly none of the QMs, if I think about it, look at the ICD-10 codes. So you need to make sure that those diagnoses are checked off. Now, the same criteria for determining active diagnoses, of course, as you know, apply for coding in the checklist as they do in the section I-8000. So you're not going to check off pneumonia if there's a history of pneumonia, but that resolved prior to the SNF stay. Now, to Tiara's question, she asked, is there any guidance on at risk for malnutrition? That is, I have not found anything specific on that. The general guideline, of course, is that the physician or physician extender would need to document that, because this is a diagnosis, so it has to be physician diagnosis. Just the dietitian's documentation is not sufficient to document in section I, because it has to be actually diagnosed, and only physicians and physician extenders can diagnose. However, the recommendation is that there are criteria to actually assign a diagnosis. So I'm not a doctor, obviously, or a nurse practitioner, but I imagine to actually code malnutrition, there are certain factors involved, such as BMI and significant lab values and things like that, which a particular resident might not have. But if they're at risk for malnutrition, you can check the same box on the MDS. So making sure that it's communicated to the physician or nurse practitioner PA that this person has been losing weight, they haven't been eating very well, they're not compliant with their diet, they're not underweight yet, but they've been losing weight and they are at risk. Can we get a diagnosis? Now, the doctor is probably going to order labs, but just making sure that the physician and their staff are aware that having that diagnosis of risk for malnutrition is really important, to make sure that gets documented, because you can take credit for it in PDPM if you're treating it. Good question. Thank you for that. I'll have to come up with some better guidance for that. But the long story short is you can't just go by the dietitian's documentation. So if you see something in the dietary note and the dietitian has not directly contacted the doctor or the nurse practitioner, please make sure that that the medical staff does see that note so they can diagnose. Okay, so let's look at the NTAs. So another thing that I looked at in the data is a breakdown of the non-therapy ancillaries. And just to shake things up a little bit, I thought I would put this in a graph instead of a table. So what I did here is I looked at the 4 quarters. So the green bar is Q2 of 2020, going all the way up to the dark blue bar here on the right is Q1 of 2021. So going from right to left to right, rather, that's our 4 quarters. And I broke up the non-therapy ancillary groups into their separate buckets. In parentheses is the count of non-therapy ancillary points that goes into each of these case mix groups. I also put in the CMI multiplier here because this is really the important thing here. The NE and the NF case mix groups have CMI multipliers that are less than 1, which means that you get less money than you normally would have had from your base rate if the resident falls into one of these 2 buckets. So that's why it's really, really important to be able to capture every NTA point that is available, such as those diagnoses of diabetes with peripheral neuropathy or diabetic retinopathy or something like that, where there are multiple areas where you can pick up NTA points. So what we saw here is, unfortunately, the largest group is one of the low multipliers less than 0, the NE category, where if I was making $1, I'd end up with 96 cents, basically, is how it works in this group. But you see here that the trend quarter to quarter has fluctuated. So the NF group, where there are 0 points, had a little bit of a spike in the second quarter we're looking at, which is Q3 of 2020, but that has gone back down again to about the prior baseline. ND, which is where you start to see a positive multiplier of 1.33, went up a little bit. Now, remember things that contribute to the NTA points, such as IV medications. Isolation adds to the NTA points, things like comorbid diagnoses, capturing malnutrition or risk for malnutrition, things like that add to the NTA points. So making sure you get all that documentation in place can push you from 2 points to 3, or from 5 points to 6. There are some people who do have patients who get into the 12 plus category, usually very, very medically complex people, or people who have HIV, that go up into these top ranges. But there is usually some room to move, at least from NE to ND, if not higher. So definitely keep an eye out on those diagnoses and capturing those comorbidities that go along with the diagnoses and the services you're providing, because the difference of 1 NTA point can get you from a negative CMI to a positive CMI for that group. I had talked about a little earlier swallowing disorders and mechanically altered diets. So here, in section K, we don't need physician diagnoses. So you don't have to have a physician write a diagnosis of dysphagia to be able to chuck anything off in KO 100. What you need is documentation of observation of things like, oh, the resident's complaining it hurts when they try to swallow, or they're pocketing their food, or there's food coming out of their mouths when they're eating, or we're identifying some difficulty swallowing. Of course, this should be communicated to the physician and communicated to therapy to see if speech needs to come in. But the important thing is anybody can either document this or tell the nurse, so the nurse can document it in the record. And it just has to happen at least once during the 7-day look back period for it to be captured. And in order to get that swallowing problem or swallowing disorder comorbidity, you only need one check in the checklist. So making sure that the observation is there. I think this is really important because you're potentially getting paid for paying attention to the patient and the resident and watching, just to make sure that they're able to eat safely. And this could happen at any time. It doesn't have to be during sit-down meals. It can be during snacks. It can be during med passes in the middle of the night at any time. So making sure that everyone knows that they have the power to either document. CNAs have their own area of the record that might capture this, or the people who are passing the trays, or the activities department who may be passing snacks, know that they can at least speak up to the nurse and say, hey, Mary seems to be having trouble swallowing now. Now, as far as the mechanically altered diet is concerned, however, there has to be an order in the record, because the diets that you're providing to these residents are pursuant to an order. So anything like a soft solids or mechanical soft diet, or ground meat, or a puree diet, or thickened liquids, just making sure that order is documented in the record so you can capture that as well, because these two together can add points to the comorbidity score for SLP and get the resident out of that SA case mix group, which I'm seeing so much of. SA is like, all right, we found nothing, no comorbidities. Now could very well be the case that you have folks that have no problem swallowing, they have no dietary consistency changes, they have no cognitive impairment, they don't have any comorbid diagnoses. I mean, that is certainly possible, but you want to make sure if there's a resident that you think maybe should have at least one comorbidity, that you're investigating those SA case mix groups just to make sure that nothing is being missed in the documentation. Now, I'm not saying to try to capture something that is not there, but it's worth a quick look in this cohort of patients. Wherever your records are, look up everybody who has an SA SLP case mix group. We're getting towards the home stretch here. Of course, I talked earlier about depression and cognitive status and the fact that interviewing or direct observation of the resident is so important to capturing this information. And that is really hampered by isolation or cohorting and just simply not being able to interact with people the way that we were able to before 2020 happened. So just remember that the requirement is still in place. CMS has not rescinded the requirement to attempt interviews however you can if the resident is at least sometimes understood, or if they need an interpreter, that interpreter is available at the time of the interview. Now, if that interpreter, and this is directly out of the manual, I'm sure you can quote it back to me if you needed to. If the interpreter is needed but they're not available, then go ahead and answer no to the gateway question and move on to the staff assessment, because you do need to be able to get that information from the resident if you can. Now, there are cases, and CMS clarified this in the manual a couple of years ago, that the interview was supposed to be done because the resident is able to be understood, or they need an interpreter and that interpreter is there available. So that interview should have been attempted. It doesn't have to be completed. It needs to at least needs to be attempted. But if that interview could not be attempted, and it should have been because the resident's able to communicate in one way or another, you're supposed to own that, frankly, to put it bluntly. So you would code that gateway question of yes, should the BIMS, PHQ-9, pain, activity preferences interview be conducted? Say yes, but then dash out the interview items. So you're basically saying, all right, I'm acknowledging this should have been done, but for whatever reason, it wasn't. But don't move on to complete the staff assessment at the same time. And this is directly out of the RAI manual instructions. If this happens, hopefully it doesn't happen very often, but just make sure you note the reason why no assessment was done in the record, because it will impact your PDPM as well as the overall assessment as a whole. If you are not able to capture any depression or cognition assessment, then you get 0 points towards PDPM in those areas. And of course, section GG, ADL function scores. I didn't want to spend 20 slides on this because section GG is a bear to begin with, but as you know, residents simply cannot be as mobile in a time when potentially sections of the facility may be isolated off or cohorted or closed off from the normal access to walk up and down the corridor, for example. So you're still basing your coding on the resident's actual performance during those 3 days, whether it is the first 3 days of the stay, or for an IPA, the 3 days ending with the ARD, or for the end of Medicare coverage, the last 3 days of the Medicare stay. Make sure you record what actually happened, but it's 3 days, but it's 24 hours of 3 days. So that means that everybody has to have input. All direct care staff should know at least what to look for and how to communicate it to the person doing the documentation if they're not documenting themselves. So that means, of course, this is ever since section GG came into existence, that this is not just for therapy, because therapy is not with the resident 24/7. It's not just for nursing, because the nursing sometimes is not with the resident because they're with therapy or elsewhere. So it really takes that interdisciplinary input to determine what usual performance is for that entire 3 days. And also remember, when the resident is coming in as a new patient to you on day one and they happen to be admitted, at, let's say, 7:30 p.m., that's still day one. So making sure that all shifts know how to do these assessments is really important. But do make sure that you're using the appropriate code if the activity didn't occur, because of course people may be too ill to attempt getting up and walking in the corridor, and or there might be environmental limitations like isolation. To make sure that you use the appropriate not attempted code. Don't dash out that item because that will impact the SNF QRP. Good question. Another question. In my experience, are facilities using nursing and therapy for GG instead of the GNAs or CNAs? I don't want to make a blanket statement because really what I'm hearing is that, nursing tend to be the people that do the interpretation, or frankly, you MDS coordinators are the people who interpret that documentation into the code to go on the MDS. So they speak MDSEs. The bulk of the documentation, I think, is still coming from the GNAs and CNAs, but we still have that complication that Section G still exists for at least another couple of years. So that becomes tricky. And that's where it's important to have that interdisciplinary input. Some centers are still kind of delegating to therapy, unfortunately, just like they always have with balance assessment, for example. And then another question, how do you address a situation when the therapist's GG assessment is significantly different from nursing? And sometimes an activity does not occur and the therapist codes it as total dependence. Well, those two things are completely contradictory to each other, right? If an activity didn't occur, it didn't occur. So it can't be totally dependent. So if you're seeing a conflict like this, verify that the activity occurred in the first place. I mean, it could have been seen by a CNA or a nurse and not by the therapist because they were off treating somebody else in the therapy gym. That's okay. I mean, it happens. And that's why there needs to be other disciplines involved in this process, because not everything is happening right in front of the therapist. So I would say that if the therapist saw it happen, then it happened, and they're documenting it as happening. If you see something in the documentation where therapy said something happened at total dependence and elsewhere it did not occur, well, it didn't occur for that one person doing the documentation, but it did occur for this other person doing the documentation over here. So you can't say it didn't occur at all because it's in the documentation as occurring. So think of it that way. You can't have those two things at once. And you are looking at all shifts for 3 entire days. So in order to document that something did not occur, it would have to not occur at all during those entire 72 hours. I had to do the math there. So in this case, just sit and think about this. Does it make sense that it didn't occur and yet it did occur at the same time? Err on the side of it occurring. Sorry, that was a little convoluted, but that was a really good question. And that takes me to this last point about Section GG. That is sometimes you have to dash, but avoid it if at all possible, because there are those did not occur codes that you can use. And if you dash, you may potentially be penalized if it happens often enough, because Section GG factors into so many SNF QRP measures. So you do want to make sure that you're avoiding using dashes as much as humanly possible. And you can do that by coming to consensus between multiple disciplines over all of the shifts during that 3-day time period. Oh, that's interesting. Walking 150 feet was coded as dependent by therapy and the patient is non-weight bearing. I would have a talk with the therapist about that, because you can't, I mean, I personally think you can't be totally dependent for walking, but I'm just a nurse. What do I know? But if the patient is non-weight bearing, then the therapist should be following non-weight bearing protocols, in which case the patient would not be, or resident would not be walking 150 feet. So I would query that therapist and say, hey, really, is that what actually happened? in which case does that non-weight-bearing order need to be changed? Good point. Thank you, Tiara, for the clarification. In section GG, dependent is also means with two helpers. Thank you. That's my section G hat. And we are about to run over, so I appreciate those questions. Feel free to shoot them at me. I probably should have devoted more time to section GG here. But one last point I want to make about therapy is that CMS is watching therapy, even though therapy does not impact PDPM as far as therapy amount of delivery is concerned. They're looking for changes in things like the average therapy minutes per day or the shift, which was very obvious from all individual therapy before PDPM to including concurrent and group therapy after PDPM. So they're looking for those big changes, which are very obvious when you look at those graphs that CMS puts out. Now the pandemic puts another wrinkle in this because you want to watch out for compliance issues such as the resident is supposed to be on isolation, but they're getting group therapy. Well, that cannot happen. They can't have another resident in the room with them getting group therapy at the same time. I mean, concurrent therapy might happen because there could be two therapists in the room with the resident at the same time, and that's okay if they're following precautions, but group therapy, or as we were just talking about, if there are inconsistencies between the ADL coding and the therapy documentation. Now, what that means, it doesn't mean that somebody is wrong. It means that they're correct for what little piece they saw. But that doesn't mean that the little piece that they saw is usual performance for an entire 3-day time period. But factor that in, is something that did not occur the usual performance or not? I mean, that's really kind of an all or nothing thing. A couple of other compliance considerations before I wrap things up, and thank you for those questions, Tiara. So just make sure that your documentation is in place to support your daily skilled services, because whatever you're capturing on the MDS, even though the MDS is supposed to stand on its own, as we know, if an auditor doesn't see it backed up in the record somewhere, it will be taken back, particularly for diagnoses that have to be written by the physician. Treatments have to be documented as given. Therapy needs to be documented as being provided. So make sure that documentation matches up with what's on the MDS. But that's where the whole interdisciplinary team comes in, so that you're not missing anything, because nobody's in the facility watching those residents and working with them 24/7. That's where the interdisciplinary communication and documentation comes in. The primary diagnosis, you can only have one, so make sure there is consensus on the primary reason for the SNF care. The skilled services need to be provided around that primary diagnosis. They can address other things, but they should be tied to the reason why this person is receiving their Part A benefit. And of course, there's the reasonable and necessary clause for the level of services addressing the reason for SNF stay, and also the duration of services, so that you probably would not keep somebody skilled for a COVID diagnosis that resolved within 2 weeks, and they finished up their isolation and it's a month later. It's probably not going to happen. So the technical requirements, don't overlook those, because you need that qualifier, either the hospital stay, or if you're skilling in place under the 3-day waiver, make sure that that is well documented, that this is the reason and this is exactly when and why this resident is accessing their Medicare Part A benefit. And that includes the physician certs and recertifications. The last thing you want after all that documentation and coding on the MDS is to have a claim entirely denied because you don't have a cert. So these are things that have always been there. They will always be there, but making sure that you don't lose that in the forest of everything else related to PDPM and COVID-19 is, just vital, because it's an easy take back. CMS will go for it. All right. Well, thanks for your time. I apologize for running over today, but this session is being recorded and I will send out the handouts for distribution. So again, thanks for your time. I appreciate it. I appreciate you, and I hope you all have a good day. Bye.